I'm Harriette Van Spall, cardiologist and clinical trialist from McMaster University in Canada, and I'm delighted to have Professor Rajesh Kharbanda here at ACC 2025. He will present the results of the routine cerebral embolic protection and TAVI trial. Welcome, Rajesh.
Thank you, Henrietta. Thank you very much for the introduction.
Let us start by talking about the context of your trial. So TAVR has increasingly been implemented as a therapeutic intervention for severe aortic stenosis across countries, but remains limited by clinically relevant complications that patients fear. Tell us about stroke as a complication, its prevalence, and what you were hoping to answer with your research question.
Yeah, so stroke, outcomes from TAVR have improved significantly, but stroke remains an unpredictable and really quite concerning complication for patients, obviously. Many of these patients place stroke as a complication that they really don't want. It loses independence. And this is, remember, an elderly population. So it's very relevant from a patient perspective. It remains unpredictable. And its frequency has reduced from 3 to 4%, now down to about 2% in most national registries. So about 1 in 50 people will have a stroke. And the majority of those strokes are embolic in origin. So either calcium from the valve or debris from the aorta itself embolizing into the cerebral circulation, leading to stroke. And so against that context, we wanted to test the routine strategy of the Sentinel cerebral embolic protection device, which is a filter-based device that deploys filters in the right brachiocephalic and the left carotid, approached from the right radial. It's a first-generation device, and those filters are in place for the duration of the procedure and capture the embolic material. So very good structure for that, hypothesis that protecting the brain from this embolic material may reduce stroke. There was one previous large trial of about 3,000 patients that was published a couple of years ago. And that trial was neutral overall for the incidence of stroke, with a numerical reduction in disabling stroke. And so the evidence was not conclusive, but certainly there was enough to suggest that there may be a benefit. And against that background, we conducted our trial, which was a pragmatic trial done across the UK. So 32 of the 33 UK TAVI centres participated in that trial. And we wanted to test whether routine embolic protection reduced the incidence of stroke. We had powered our stroke on a 3% stroke rate, reducing to 2% with intervention. And we required 7,730 participants. So that was the trial design, and that was the context.
Sure. What was your primary outcome?
It was stroke, all stroke at 72 hours or at hospital discharge, whichever was sooner.
Require imaging confirmation?
Yeah, this was a clinical trial, so we didn't use imaging, routine imaging as an endpoint. This was a clinical trial, and so this was clinical stroke. Obviously, imaging was used by stroke physicians to confirm use it for the diagnosis of stroke, but this was a clinical diagnosis. We used so there was no routine neurology assessment, but we used a validated questionnaire to assess stroke-free status, the QVSFS, which is widely used in trials of stroke prevention. And we used that to validate stroke-free survival. And if that was positive, then the clinical team instituted the local pathways for stroke assessment. And all events were adjudicated by a blinded panel of senior stroke physicians, both from the North America and Europe, who adjudicated each event in a blinded manner.
What were the baseline characteristics of the groups?
Yeah, the baseline characteristics were very well matched of a typical aortic stenosis population. So we had mean age was 82. We had good representation of females, 38% females. We had about 8% representation of bicuspid valve pathology. They were well matched for diabetes, peripheral vascular disease, and Euro score was 2.4 in both groups. So a standard population of TAVI patients well matched. And we recruited 1/3 of, well, 30% of all TAVI cases that were occurring across participating sites. So the population was really, for a trial population, very representative and not select as we could be. So this was very much a pragmatic national trial enrolling a high proportion of eligible participants.
Sure. And tell us also procedural characteristics. How did you standardize them um, with regards to the procedure, the devices, and some of the recovery process?
So we did not specify that in any way. So exactly, and I think that speaks to why, we had over 3,700 participants in each group. So just by randomization, those features would have been matched. Balloon expanding valve use and procedural characteristics were also well matched between the groups. So there were no differences in terms of the procedural characteristics. But we did not specify that for the trial. This was very much testing a strategy in routine clinical care approach.
Sure. What were the results?
So the results were that for all stroke, the control group had an incidence of stroke of 2.2%, and the embolic protection group was 2.1%. And for disabling stroke, the incidence was 1.4% in the control group and 1.2% in the embolic protection group. And that was neutral with confidence intervals that included 0, so that there was no effect of embolic protection either on all stroke or disabling stroke.
Your sample size estimation was based on the assumption of a larger risk reduction that you did not see in the trial. So could your neutral effect have been a function of an underpowered trial?
Yeah, that's an important question. I mean, the trial was stopped by the Data Monitoring Committee for futility at the third interim analysis. So we had pre-specified futility criteria, but the actual number of events was 82 in the control group and 81 in the embolic protection group. So they were almost identical, those numbers, and to show an effect would have required an inordinately large number of extra participants. So I think it's unlikely that this was underpowered in terms of a clinically meaningful reduction in events.
Right. And this is not uncommon for a trial that has some pragmatic elements because certainly explanatory study designs um, allow us to be more specific in how the intervention is delivered. So, important point that you made earlier was that you were testing a strategy rather than a highly controlled device or procedure. Did you measure all-cause death?
There was no difference in mortality with this mortality. But remember, this was the primary result of the trial. So this was 72-hour and discharge before death with
Sure.
disabling stroke at 6 weeks. So in that short period, there was no difference in all-cause mortality between groups. But we may see an effect, and the trial is still under follow-up for 12-month follow-up. So there may be some later signals that evolve, but certainly nothing at the moment.
How about safety events?
Yeah, there were no concerning safety signals that we could identify. Uh, so, as far as we know, the device remains safe, but neutral for the primary endpoint.
Sure. And how did your findings fit in with prior evidence? I know there was a preceding PROTECT-TAVI trial, and there have been other observational studies. So tell us about the larger evidence based and how this was concordant with the prior research on the subject.
Yeah, so as you mentioned, Protected TAVA was a study that was published. That was 3,000 trial participants, and that was also neutral for the primary endpoint. There was a numerical reduction in disabling stroke, which was really hypothesis generating because it wasn't large enough, and our trial was was double the size of Protected TAVA. Um, so in that sense, it confirmed the neutral effect on the primary endpoint and the disabling endpoint is also neutral, which in our larger study. We are planning a combined patient level meta-analysis. There has been some work from observational registry data, suggesting a very small effect of the device, particularly in participants who've had a prior stroke. But as with all observational data, there are probably a number of unknown confounders which is why we needed the randomized trial really to sort of pin that down.
Sure. So important trial with a clinically relevant finding that routine cerebral embolic protection does not reduce the risk of stroke at 72 hours post TAVR. Why do you think the intervention was neutral?
Well, I think we've TAVR's got better. Stroke incidence has come down. And the frequency of the primary end point was lower than we'd anticipated. So we'd anticipated 3%. It was down at 2%. And I think clinical practice has improved. So the incidence of the primary endpoint is lower. Um, and as a routine strategy, therefore, you're looking at many participants who may have even lower risk of stroke, and therefore it's much harder to show an effect. So perhaps this is because of the routine nature, and it's possible that a more stratified approach may be beneficial in a population with a higher stroke risk. And that's certainly something that we need to look at in the future about how we identify that population and then whether there is a role for embolic protection in that group. But I think it speaks to a lower event rate occurring, and the mechanism of stroke may not always be embolic. So, for example, participants who suffer a procedural complication may have stroke for other reasons that the device won't protect from. So it depends. So it's probably a combination of those factors.
Sure. Well, Rajesh Kharbanda, thank you so much for joining us this morning. Congratulations on your late breaking clinical trial presentation. And we wish you all the best for your ongoing analyses of this important trial.
Thank you so much.